And first speaker will be Dr. Raguraman from Madurai. He will talk about thyroid function test, the red flag signs. I hand over the mic to my co-person.
Good morning, everyone. First of all, I'd like to thank the organizers of the receptor and my classmate and friend, Dr. Kumarave, who's actively involved in all this. And, the first speaker will be Dr. Raguraman R. And he did his MBBS in Madurai Medical College and MD General Medicine in Amritsar Medical College, Amritsar, and DM Menda from Guwahati Medical College, Guwahati. So he's currently working as a consultant endocrinologist at Bharati Hospital, an Alpha Hospital Research Center. Over to you.
Good morning, respected chairperson and delegates. Today the topic for discussion for me is red flag signs in thyroid function test. So this is the agenda for today's meeting, and diving straight into the topic, the introduction. Thyroid function test is a routine test which is conducted in the inpatient and outpatient in day-to-day practice. The TFT includes normally TSS, total T3, total T4, and total T3, free T3 and free T4. TFT, while it has a wide range of alterations leading to dilemma in clinical practice. So red flag signs are situations where practitioners treat the patient unnecessarily sometimes, or treat them with wrong drugs, or don't treat them at times when it is needed at most. In this session, we are discussing about how to manage these situations better. So first, before going to this one, that is laboratory techniques involved in thyroid function test. As we know, endocrinology is dependent on accurate lab measurements, and these needs to measure the hormones which are in low concentration, very low concentrations in the blood and plasma. There are different methods available for testing these thyroid hormones, which includes like immunoassays, immunometric assays, and LCMS. For free hormone reduction, the testing is much more difficult, which involves because of the T3 and T4 should be separated from the binding proteins. The different tests includes like direct methods like equilibrium, dialysis, ultrafiltration, indirect methods like immunoassays, thyroid hormone binding ratios, thyroid binding globulin immunoassays. These things are all some of the indirect methods by which we can assess them. Among these methods, equilibrium dialysis is the most best one. And the interferences from in these due to laboratory techniques arises from either from heterophile antibodies or from variant binding proteins which have different altered affinity to T4s. If we are suspecting any interferences due to the laboratory techniques, repeat the test in a different method. Something like when a patient is having hemolysis or hyperbilirubinemia, we can go ahead with radioimmunometric assays rather than fluorometric assays, which gives a better result. Similarly, while we are knowing about this one, the important rule which should be known is the inverse log rule. That is, there is an inverse log linear relationship between free T4 and the TSH, which results in the small changes in free T4 produces greater changes in TSH in the opposite directions. If this rule is not fulfilled in any of these conditions, we can suspect interferences in the assays. And one of the major causes is the heterophile antibodies, which are weak multispecific antibodies. These are majority anti-mouse antibodies. So any test which uses mouse antibodies for the testing will be affected. In this test, these heterophile antibodies produces falsely positive, false high results. That is, for example, a patient who is on hypothyroidism, who is on regular treatment and was previously controlled and has sudden increase in TSH level reduced but normal free T4, we can suspect one of the reason is this one, that is a heterophile antibody. This is being produced because these heterophile antibodies can bind both to the capture and to the signal antibodies at the same time, resulting in falsely high levels. Now, the simple interpretation of thyroid function test, that is normal, the straightforward, most easy one is the TSH levels more than 10 and total T3 and total T4 are less. This is a straightforward case of primary hypothyroidism which can be easily treated with levothyroxine. But other than this, there are multiple test differentiations which will be very difficult to identify. These are all mostly the red flag signs. In this one, we will be discussing about differentiation between secondary hypothyroidism and sick euthyroid syndrome, differentiation between secondary hyperthyroidism and thyroid hormone resistance beta, thyrotoxicosis, pregnancy, neonates, and subclinical hyperthyroidism in elderly, and some drug effects and miscellaneous causes. So, this is the scenario where you will be seeing a 32-year-old female admitted in ICU for refractory shock and some inotrope support. She has been called, your opinion is needed for DSTFT, where your TSH is decreased, T4 and T3 are also decreased. In the second case scenario, you will find that a 53-year-old male admitted in ICU for CVA for DSTFT. This patient also has decreased TSH with decreased T3 and T4. So both the patients have similar lab reports, but one patient requires treatment, other patient does not require treatment. How to proceed again to this? As usual, the first is clinical signs and symptoms. So first patient had a abdominal pain, 2 episodes of vomiting today, and patient was amenorrheic for the last 3 years following childbirth, which had severe bleeding. So this is kind of like going into the picture of Sheehan syndrome with early secondary hypothyroidism. In the second case, it is like the patient is not diabetic and hypertensive, admitted for CVA with ICH and intraventricular bleed, with on ventilator support with a poor GCS score. So this goes in the favor of sick euthyroid syndrome. So how to proceed further? So as we have mentioned, the symptoms should be the first one, where you are evaluating for loss of appetite, lethargy, other hormone deficiencies, presence of acute critical illness like stroke, shock, and sepsis. So, in this case, other hormone deficiencies symptoms are more important because once thyroid is affected due to secondary hypothyroidism, most of the other hormones will also be affected, like secondary, that is gonadotropin deficiency, cortisol deficiency, growth hormone deficiency would be present. So, in examination also, you can look for those hormones like BP, low BP, hypotension, loss of secondary sexual characters. These things could be seen there. And the major investigation which is used here is reverse T3, but that is not available here. It will be raised in sick euthyroid syndrome, but it will be low in secondary hypothyroidism. Other hormone profile, so the other hormone profile like cortisol testing, LH, FSH with testosterone or estrogen will help you to please the diagnosis here. So as you mentioned, the treatment varies. For sick euthyroid syndrome, you have to treat the cause, but for secondary hypothyroidism, we need levothyroxine. Coming on to the second picture, that is 18-year-old male has been referred for thyrotoxicosis symptoms. But his TFT is showing like TSH is slightly increased, total T4 is increased and total T3 are also increased. And similarly, there is a 5-year-old boy who has been referred for DSTFT on routine checkup. His TSH is also increased, but total T3 and total T4 are also increased. Here, in both cases, the inverse log rule is not obeyed. This is one case where we have to differentiate it between secondary hyperthyroidism and thyroid hormone resistance, that is beta mainly. So, how to go ahead? We have to look for signs and symptoms. First, in the first case, the patient had a mild temporal loss of vision with headache. On examination, there was third nerve palsy. But in the second case, patient was not having any symptoms, and patient was having slight anxious with pulse rate of 112, but his height is on the lower range, that is 50 to 10 cm. Patient was also having grade 1 goiter. So first is going towards TSH soma with mass effect, and second one is going towards thyroid hormone resistance beta. So how to proceed in this case? As seen, we have to ask for some thyrotoxic symptoms and hypothyroid symptoms. Here, in the case of thyroid hormone resistance, it will be either sensory neural hearing loss, or short stature, or delayed bone age. These are all some of the other presenting features of thyroid hormone resistance beta. A goiter might be present in both the cases. In investigation, here investigation plays a major role, where MRI brain will be helping to find you the TSH soma, that is pituitary mass. Other than that, there is one more thing, that is alpha subunit to TSH molar ratio. If it is more than 1, it is suggestive of TSH. Genetic analysis again to confirm the thyroid hormone resistance. Sex hormone binding globulin. This also plays an important role in thyroid hormone resistant beta, where it is reduced, but in TSH it will be raised. And T3 suppression test and TRS stimulation test are some dynamic tests to differentiate between these two conditions. And in treatment also varies. For secondary hyperthyroidism, it is antithyroid drugs and thyroid surgery. Whereas for thyroid hormone resistance, it is normally they don't need any treatment, but sometimes we can use thyroid hormone analogs, that is trial. Coming on to the next scenario, here a 35-year-old female who has history of thyrotoxicosis features for only 3 weeks, but patient had history of fever 4 weeks back with URT. Her TSH was decreased, T4 was on a higher level, but T3 is on the lower level, is on normal level. Sorry. And in the second case, 28-year female was referred for TSH low, and total T4 and total T3 were high. Patient had thyrotoxicosis symptoms for last 1 year. So this is two differentiating cases for thyroiditis and Graves' disease for how to proceed again. As usual, go ahead with first symptoms and signs. The first patient had tremors and hyperhidrosis, but the goiter was firm, grade 1 goiter, but very tender to touch. So this is again fitting into subacute thyroiditis. Whereas the second patient had tremors with grade 1 goiter, but it was smooth, it was non-tender, and there was associated thrill and bruit, which is again fitting in towards Graves' disease, which is also again, the patient also had mild inactive thyroid associated ophthalmopathy. So this is going towards Graves' disease. So what are the other investigations can be done here? So before going into it, the onset of neck, if there is a neck pain and short onset of thyrotoxicosis symptoms, is again favoring towards thyroiditis. And as I had mentioned, presence of bruit or thrill will fit into Graves' disease. Consistency wise, if it is soft, it is most fitting into Graves' disease. Investigation, the major investigation which should be done in a case to rule out thyroiditis and hyperthyroidism is thyroid technetium 99 radionucleotide scan, where there will be decreased uptake in thyroiditis, whereas increased uptake in hyperthyroidism. ESR CRP will be elevated in subacute thyroiditis, and TRAB will be elevated in Graves' disease. These are all other investigations. As you know, thyroiditis will be treated with beta blockers and steroids if needed. Hyperthyroidism will be treated with antithyroid drugs. This rare presentation of TSH low with T3 and T4 high may be present even in stroma ovary and identiform or cholelcarcinoma. So ask for those symptoms like abdominal pain, abdominal mass, or amenorrhea. So the next scenario, the patient of 24-year-old 10-week pregnant lady has come for deranged TFT. Her TSH is low, but total T4 is high. Patient has symptoms of palpitations and dyspnea on exertion. The second case, patient is also 26-year pregnant lady with 8 weeks of gestation with twin pregnancy. She also has come with deranged TFT with low TSH, but total T4 is in the normal range. She has no thyroid symptoms. So again, this is again differentiating feature for hyperthyroidism in pregnancy, the first case, and second case is a case of thyrotoxicosis of pregnancy. So again, how to differentiate? That is doing clinical signs and symptoms. The first patient had symptoms, second patient had no symptoms. And in examination, the first patient had goiter with the bruit suggestive of Graves. Second patient, the thyroid examination was normal. So to understand these things, you have to know about the physiological changes. Normally, in pregnancy, the TSH level decreases mostly in the first trimester due to increase in TSH. The total T3 and total T4 will increase by 1.5 times due to the estrogen effect, whereas pre-T4 remains normal approximately. The iodine requirement increases in pregnancy, where RDA is coming to about 220 micrograms, and there will be increased iodine excretion in pregnancy. So, in clinical setup, what is the thing? Any TSH rearrangement should be evaluated in pregnancy, should be evaluated. And for cutoffs for TSH is in first trimester is 2.5 and in second and third is 3. Anything more than this, treat it with levothyroxine. If it is low TSH is present, as you should ask for thyroid toxic symptoms and investigation, do at least a rule out Graves' disease. If needed, you can go ahead with USG and doctor. Because in treatment wise, hypothyroid, you have to do the same treatment as a normal patient only, use levothyroxine. But in hyperthyroid, first trimester use PTU, propylthiouracil, and second and third trimester, you can go ahead with methimazole or carbimazole. Coming on to neonates, this is a first case where a preterm baby called for TSH of 12.8, which was done after 72 hours with normal free T4 levels. The second one is also term baby, is a term baby with TSH of 23.6 and free T4 on the lower range of normal. 0.8 will be the most of the cutoff in most of the laboratories. So here, again, how to differentiate? How to go ahead, because the first patient might not need treatment right now, but it needs close follow-up. The second patient requires some treatment. Why? How to proceed? We have to ask for symptoms of hypothyroidism, and present thyroid examination was normal in that one. Whereas in the second case, thyroid was not culpable, and again USG confirmed that there was thyroid agenesis. So the second patient required treatment. The first patient might require treatment later on, but it should be followed up closely. So how to go ahead with it? So before this, we have to understand the physiology in this. The TSH surge occurs immediately after birth, that is at 30 minutes after birth. It leads to free T4 rise. This again inhibits the TSH and leads to falling TSH levels. And after birth, the metabolism, T4 metabolism changes from high T4 metabolism, where reverse T3 is a major product, to low T4 levels, where T4 becomes low T4 metabolism, where T4 becomes a major product. And preterm neonates, the TSH surge is less prominent, so the cutoff is not exactly available. Only for term neonates it is available. Lesser free T4 is also it is preterm, that is lesser T4 compared to that of term neonates. So we cannot have perfect cutoffs for preterm neonates. These patients with preterm should be followed up regularly. So here you will find that there will be that initial for hypothyroidism neonates. After 72 hours, do a dry blood spot test, heat prick test, that is with TSH alone. If TSH is more than 40, treat it with levothyroxine. If it is less than 40, do a venous sampling. And if the TSH is more than 20, you can start treatment directly. And if it is less than 20, that is 6 to 20, you have to look for free T4 levels. If T4 levels are low, then treat. If it is normal or if the TSH is less than 6, you can keep the patient on regular follow-up, that is every 2 weeks. And if the TSH levels are further rising, then you can go ahead with treatment. And in hyperthyroidism, the cutoff is same, but the treatment should be aggressive, like thyroid stop. Coming on to the next case scenario, here 65-year-old male evaluated for fatigue, and evaluation he had subclinical hyperthyroidism with low TSH with normal PT3 and T4. Whereas the second patient had 53-year-old female with AF and CCF, and patient was evaluated and was found to have subclinical hyperthyroidism. Here, both the patient require treatment, but why? This will be seen in the next slides. And this one examination was normal, the first patient, but the second patient had a pathological fracture in radius 1 year back. So, subclinical hyperthyroidism, it is the same as per symptoms. As per symptoms, the investigation is same as hyperthyroidism, but the treatment is changed. It is based on the age. If the patient is more than 60 years, then you have to treat even if it is subclinical hyperthyroidism. But if it is less than 60, look for atrial fibrillation, osteoporosis by DEXA or by any fracture, previous fracture, pathological fractures, and presence of CA, the coronary artery disease. If any of these is present, you can treat subclinical hyperthyroidism. Otherwise, no treatment is needed. So, coming on to the next one, that is elderly. Here, the physiology is that the TSH levels progressively increase. It rises up to 7 at the age of 80 without any change in free T4 levels. So, Subclinical hypothyroidism is frequent and it is frequently transient, so don't need to treat it immediately, but review it after 1 month if needed. But subclinical hyperthyroidism is dangerous in an elderly patient because it is a risk factor for atrial fibrillation, coronary artery disease, and fracture. So treatment is indicated even if TSH is between 0.1 to 0.4. So what is the clinical implication? TSH less than 7 in an elderly, that is more than 60 years, you can wait and watch, don't treat it immediately, but more than 7, you can consider treatment. And less than 4, you have to start treatment. And in treatment for hypothyroidism, in younger age group it is less, you can maintain it less than 3. But here in elderly age group, you can maintain it at around 4 to 6. Coming on to some miscellaneous causes. We are leaving out amiodarone because you already know that it will cause either hyper or hypothyroidism. We are coming on to other drugs where steroids is like TSH might be low and T3 might be low, but this is T4 is normal. This is because steroids inhibit the TSH production and peripheral conversion of T4 to T3. And biotin effect will mimic that of hyperthyroidism where TSH is low, total T3 and total T4 is high. This is because biotinated antibodies are used to be captured in solid particles. Most of the assays use biotinated antibodies. In heparin, the TSH will be normal, but T3 and T4 will be increased. This is because heparin induces lipolysis by activation of lipoprotein lipase. So once non-specific fatty acids are increased, it displaces T3 and T4 from their binding proteins, especially albumin, and it will lead to falsely elevated T3 and T4, free T3 and T4. This occurs only when only when estimated fat state is more than 3 millimoles. Other mentions are dopamine and somatostatin decreases the TSH, bile acid sequestrants, calcium carbonate, caspofungin, and proton pump inhibitors inhibit the T4 absorption. So there should be a gap of around 3 to 4 hours between levothyroxine and these drugs. Enzyme inducers and inhibitors change the dose of levothyroxine. And one more important thing here is that your T3, total T3 and total T4 might be increased, but TSH will be normal. Free T3, T4 will also be normal in some cases. This is due to the alteration in binding proteins. Some of the conditions where it is increased include estrogen, pregnancy, and familial dysalbuminemic hyperthyroxanemia. And it is decreased in nephrotic syndrome, illness, and CLD and steroids and androgens. One last case where we will have levothyroxine absorption defect is a patient who is on about around 200 microgram, but still his TSH is not controlled. That is, his hypothyroidism is not controlled. Patient reports that there is good compliance, there is no drug effects, and the patient is repeated test was done in different labs, but it is almost the same. So we can go ahead with levothyroxine absorption defect. There are multiple methods to do it. But the most common endpoint is like you have to look for rise in free T4 levels. If it is less than 0.4 at around 3 hours, it is suggestive that patient is having malabsorption. So you can look for any malabsorption syndrome like celiac disease, ulcerative colitis, like that.
Excuse me, sir.
Yes, last. So how to avoid it? Don't go with foregone conclusion. And correlate the clinical findings with lab reports, understand the physiology in neonates, pregnancy, and elderly. Always ask for the drugs taken by the patient, and if needed, you can repeat the test in a different method. So, concluding points are TFT should be correlated with clinical scenario, know about the inverse log rule between TSH and T4. If needed, repeat the test in different assays. Do necessary investigation to narrow down the correct diagnosis. In any case of doubt, get expert opinion. Thank you.
Thank you, sir. That was very beautifully explained. Clearly differentiating between all the conditions. Very nice. The questions, one or two from the audience.
How to differentiate thyroiditis from hyperthyroidism? Different points without any clinical results.
Without any, sir?
Without clinical presentation. Tell me what is the difference between thyroiditis and how to differentiate thyroiditis from hyperthyroidism?
When there is a short duration of symptoms, that is less than 1 month of duration, it can suggest for thyroiditis, but still we have to confirm it only with any investigations. But clinically, there will be one major difference is that goiter will be soft in a case of hyperthyroidism, that is Graves' disease, and presence of bruit in clinical examination, bruit or thrill in examination will suggest that patient is having hyperthyroidism. And on touch, if it is tender, if it is the thyroid is tender to touch, it is suggestive of subacute thyroiditis. These are all major differentiating points in clinical practice. But to differentiate, best investigation is like radionucleotide scan, that is technetium scan, which is easily available. Which will, if it is decreased, it is suggestive of thyroiditis. But if it is increased, it is suggestive of hyperthyroidism.
Dr. Ramanathan, you want to ask? Okay, we'll go to the next speaker.
Thank you.